run like 20 minutes.
Oh, you run 20 minutes. Okay, okay. Nice. Good to see you. Good to see you. I haven't seen you in a while. So, Nestor, are we moving the closing ceremony or are we still doing something today? Do you know?
Yeah, like 11 p.m.
Yeah, but we didn't get all the speakers, I think, and Jorge wanted to do another official one another time, but I can come in at 11 and make and say a few words.
Okay, yeah.
It's no problem.
It's fine. It's great.
Okay, okay.
We are live on Facebook and YouTube, doctors.
Great. Go ahead and start, please. Okay, who's going first? Are we doing the Spanish first?
I think I go first, if possible.
No. We have to introduce you.
Okay.
Yeah, we wait a doctor who are going to present in Spanish, and then I go present in English.
That's fine. Is it Guillermo who's going to present or Karen?
Apparently, and I'm going to present in Spanish too. Well, buenos días a todos y bienvenidos. Bueno, continuando con nuestro programa de hoy, al nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y chairman del World Congress of Neurosurgery, UNESCO ASPNet, Walter E. Tandy, in honor of Professor Yaşargil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, chairman del capítulo ASPN, al doctor Salim Abdulrah, chairman del Walter E. Tandy Neurosurgical Society, al doctor Babaka Deb, chairman de la Society for Brain Mapping and Therapeutics, y The Brain Mapping Foundation, todos ellos vice chairman del comité organizador, al doctor Parménides Guadarrama Ortiz, chairman del Centro Especializado de Neurocirugía y Neurociencias en México. Well, hello everyone, and continue today's program of behalf of UNESCO Ambassador Jorge Herrera Ramos and chairman of the World Congress of Neurosurgery, UNESCO asked Walter E. Tandy, in honor of Professor Yaşargil, whom to take for organizing this great event, as well as Dr. Deyanira Capi Casillas, chairman of the ASPNet chapter, Dr. Salim Abdulrah, chairman by Walter E. Tandy Neurosurgical Society, Dr. Babaka Deb, chairman of the Society for Brain Mapping and Therapeutics and Brain Mapping Foundation, all these chairman of the organizing committee, and Dr. Parménides Guadarrama Ortiz, chairman of the Center of Neurosurgery of the Center of Neurosurgery and Neuroscience of Mexico. It's an honor for me to present of the following presentation by Dr. Surin Matutes Fableo. He is he is professor and consultant neurosurgeon in Daman University since 1994. He born in Egypt on March 24, and His area of interest are neurosurgical practice, full involvement in busy neurosurgical service, operate till more than 6,000 neurosurgical patients, special interest for pediatric neurosurgery, and special interest in pediatric neurosurgery and head trauma. His education dedicated and writing 3 fellowship training programs in Saudi Arabia, Egypt, and one of the scientific contribution and achievement are books and publishing chapters, manuscript, and presented lectures. One of the discovered in neurosurgical disorders are described and named special neurological and neurosurgical condition in children, which was published in Journal of Neurosurgery. One of your invention obtained 5 patents and failed to obtain 2 more patents from USA. And her current scientific research are the long outcome of male head trauma, the long outcome of hydrocephalus, and with genome of epilepsy. The long outcome of male head trauma, and he also is an editor and review of international journals. And well, it's also great honor to have Dr. Salim Abdulrahman, who also is a professor and chairman of the Department of Neurosurgery in St. Louis University, director of St. Louis University Center for Cerebrovascular and Skull-Base Surgery, neurosurgeon in chief, St. Louis University Hospital, interim director, Division of Pediatric Neurosurgery, Cardinal, and in Glennon Children's Hospital, and global president, Walter E. Dandy Neurosurgical Society, which is considered the primary international society for operative neurosurgery.
Thank you, Nestor, for your comments. It is an honor to introduce an old friend and colleague today. Thank you, Nestor, for introducing me. My main role right now is the neurosurgeon in chief of the Abdulrahman Institute of Neurosurgery. But thank you for your introductions. I want to introduce Professor Ahmed Ammar. He hails originally from Egypt, but for the last 2 decades, he has contributed to the neurosurgical education in the country of Saudi Arabia in a significant way. He is respected by the neurosurgical colleagues in that country for all the contributions he's made for a generation of neurosurgeons that were trained in that country. He also has made significant contributions himself. He co-authored a book about ethics in medicine and neurosurgery, and it is a personal pleasure to have him here with us today to give us his perspective. Professor Ammar, it's great to have you with us.
Thank you very much, Professor Abdulrauf. It is always a pleasure to meet you and talk to you. And thank you, Nestor, for the introduction. It's great to, always to work and cooperate with you, with a great neurosurgeon like you. Now I can start. If I can share the screen. Yeah. So I think that is, all of you may agree that is modern neurosurgery is thought to be based on evidences. But the fact is, neurosurgery, since medicine, since it started, since the early age, was based on values. And actually, there is no conflict between values based medicine, as we call, and evidence-based medicine. I have nothing to disclose to report, but I would like to say that is medical, there are always very important question. Are the medical ethics are universal or local? Means, that is, if we apply or talk about medical ethics in North America, can we talk about the medical ethics in the same terms, same definition in Far East, for example? And the answer, simple answer without going too much philosophy, yes. As for example, friendship, honesty, gratitude, patience are among universal values. And also that is a medicine. However, the interpretation can be different from place to place, and the understanding can be different. But bioethics is not an exception for that. So the ethical roots and principles are universal. However, the interpretation and the implementation may be slightly different. So that's why we came to an ethical term, what we call ethical relativism. What means that is ethical relativism can be defined as the theory which claims that because different societies have different ethical beliefs, there is no rational way of determining whether an action is morally right or wrong. So what's considered morally acceptable or desirable in one culture, country, religion may be ethically unacceptable or undesirable in different culture. So there are actually, if we talk about ethics, we have to think about three different perspectives. First of all, the perspectives of the researcher, philosopher, because ethics had been left for many, many years, hundreds of years in the hands of the philosopher. And recently, the neurosurgeon, who are really implemented the ethics in everyday work, and also the other doctors in practice. And more important, patient and their families. And how do they look for the medical ethics? Here we come to an old question, which one was asked by William Osler. Who is the physician? Who is the surgeon? Who is the neurosurgeon? And he said, we are privileged to have the duty to give care to the patient. So that is, we are the people who are giving care and the best care for the patient. We are here to add what we can to life, not to get what we can from life. And the good physician treats the disease, but the great physician treats the patient who has the disease. This is to simplify, that is the real meaning to be a good neurosurgeon who implemented ethics in every step. So medical ethics, what has happened in the last few years? That medical ethics was always written, it is there for hundreds of years, but it's written in the books and the books on the shelves. What's happened in our movement in the last few years, that is we started actually to implement the ethics and to reintroduce it by in the patient wards in the hospital, and this introduction or this implementation is done by neurosurgeon. So that is why actually in the last, we were surprised actually to see this, that is 2014 was the first book written about neurosurgical ethics in practice. And we introduced at that time value-based medicine. That's from Mark Bernstein and myself. 2019, there is in a book, another book about bioethics, neurology, psychiatry, and genetic, and I wrote a long chapter and introduced the term values-based medicine and found the relationship between find-based medicine and evidence-based medicine. 2019, a colleague from Holland, Mark Broekman, wrote a book about the ethics of innovation in neurosurgery. Last year, that is another book in ethics in neurosurgery practice by Australian colleague Stephen Honeywell, and I have 2 chapters in that book. So that is the people started to rethink again about this issue. So if we look about our perspective of ethical implementation in the daily practice, We have to say first about ethical related to the patient, about decision making. How do you make a decision? Decision related admission, decision related priority of surgery, decision about follow-up, all this. This all has, ethics has a role to play in it. Priority of admission is consent. And this is also a very important ethical issue. Autonomy, patient rights. And patient rights to know about everything related to them. Diversity of management. As all of you know, that is a neurosurgery, for example, there is very seldom to have one way of treatment for a single disease. There's always several options. So how to choose the options? It's not only because you prefer that option, all the facilities are available, but also ethics playing a role for how to choose. Another thing which is very special for neurosurgery, what we call certainty of uncertainty. The long-term outcome of many of neurosurgical problems, like severe head trauma, especially in children, like some tumor, like subarachnoid hemorrhage in special grades, grade 3 or grade 4 or something like that. You cannot tell about the certainty, by certainty, about the long-term outcome. So this is what we call it medical ambiguity. It is an ethical question. Ethics of evidence. When we talk about evidence, how evidence is an evidence? This is not a philosophical question. This is very much an ethical question. And how do you obtain an evidence? What makes things evident, for example? This is very important ethical. So not everything we say it is an evidence. Maybe it's not an evidence if you apply ethical rules to it. So another issue which is very important about holding or withdrawal medication or denying surgery or brain death, even brain death. All this also ethical question we face every day in the hospital. Then this is related to the patient, but what about the relation to the patient family? Ethical professional approach to the family. How do you take to the family? How much confident information do you tell to the family? Who may sign the consent for the patient if the patient cannot sign? All this ethical question. Then come an important question in these days about quality of life. As for example, management of severe, we will come to it in the end of the talk. Quality of patient with severe head trauma and grade 3. Shall you do decompressive craniectomy and get the patient at vegetative, or you don't? This is not a practical surgical question only. This is an ethical question. And the family has to have a part in making that decision. Rehabilitation and the quality of rehabilitation. And the healthcare resources and distribution of the healthcare resources. And justice. Justice, as you will find out, it is one of the most important principles of ethics. Research, innovation, invention, first surgery, first trial, first equipment, first medicine. All this is an ethical question. As we know these days about the problem with the vaccine, COVID-19 vaccine and other things. Medical litigations. Medical litigation is also an ethical problem, not only because it's a court issue, but because when you are asked as a witness to go to give your statement, this is a very important ethical question. Career development and respecting your seniors. And this is also very important ethical issue. Working environment and relationship between colleagues, seniors, nurses, paramedics, trainees, students. All this ethics are playing a role in it. Training, supervision of program, publication, working environment. And not only that in the hospital, but even beyond the hospital, in the city, in the country, in the whole world, you have to be a good citizen of the whole world. This is all ethics. So what is value? To make it simple, value is value when its value is valued. What do you mean? That is, we value if we value something. So that is the value. But if we don't value something, I cannot convince you to value it. That is value what you value. Okay. So value also is always, as we said, can be different. So for example, if we shed a light on this cylinder, so if it is come from the side, you can see it and interpret it as a square. You can say this is a square. And if you look at directly, so you say this is a round thing. But the value actually, or the ethics, it's not that, not that. You have to look at it in 3 dimensions. So that's what came us to as an ethics, to be more precise what we are talking about, and not to leave it just to the philosophy. And when we talk about neurosurgical ethics, we talk about real. We would like to make it in more understandable and can be implemented in our daily practice. So the question is the ethics what we believe or what we practice? Or both? Or is it what we understand or what we interpret? Or is it what we value? Or is it a behavior, ethical behavior, or ethical thought? Or it is an individual ethics, or it is a group ethics? In fact, it is all of this. Ethics is all of this. So what is ethics? If you go to the philosophy again, so we'll find it is a moral philosophy. Ethics is concerned with question of moral issue. How people search for the right conduct, what's right and what's wrong, and how people are ought to act or are acting, is or to be. Or the act should bring good life and satisfaction, consequentialism, and that's also a branch of ethics. So it is at the end, what's right and what's wrong, and what should be done, or what is done, is happening. And so there are actually, if we go, so there are 3 different types of branches, main branches of ethics. One is called meta-ethics, and normative ethics and applied ethics. Meta-ethics, it concerns about the nature of ethics, ethical theories itself. What does the values such as good, bad, right, wrong mean? So if I say this is good, what does it mean? Or are these judgments universal or relative, as we said before? And how can we know something is morally right or morally wrong? So is it not enough to tell you this is right and this is wrong, but how can we know? How can you be sure about this? Normative ethics, this is medical ethics, bioethics comes under normative ethics, by the way. Normative ethics is a study of what makes action right or wrong, what makes situations or event good or bad, and what makes people virtuous or vicious. Normative ethics emphasizes on 3 elements: the person who performs the act, and the act itself, and the consequences of the act. Then the last type of branches of ethics is what we call it applied ethics. Applied ethics is the actual application of ethical theory for the purpose of choosing an ethical action in a given issue. In simple terms, an applied ethics issue is more than a mere social issue. It must be morally relevant. And some people, they put the medical practice sometimes under applied ethics, but actually most of philosophers, and we do, put it under normative ethics. So normative ethics theories, there are many branches of it as well. Normative virtue ethics, it focuses on the inherent characters of person. The virtues are identified as those habits and behaviors that will allow a person to achieve eudaimonia, or happiness, or well-being, or a good life. So the thing is which makes the life good for you and for everyone around you. Deontology, it means that it's approach to ethics that focus on rightness and wrongs, or actions themselves. It is under it comes the law, the regulation, the state's regulation, family regulation, everywhere. Consequentialism or theological ethics is the defining the morally right action is one that produces a good outcome or consequence. So there's a very big difference between virtue ethics and the conceptualism, because it doesn't judge the action itself, but say the action can be right if the result is right. Maybe some people agree or not agree, but this is one of the ethics. So the emerge and evaluation of the principle of bioethics through the years. So the hundreds of years. In early years, it was also referred as a humanized medicine. And the cultural value of ethics principle regulated and guarded the medical practice in all the civilization, as well as having in our current practice. So we can see actually in all the Egyptian civilizations and all the Chinese civilization and all the Indian, all of this, we have a lot of documents to say how that is they valued the body and valued the intervention to treat the patient and the values that is. And in fact, this is how was restricted to be working as healer or doctor or something in this older culture. But the real principle of medical ethics or the roots goes to the Greeks. So Hippocratic Oath actually made it very clear. It will prescribe regime for the good of my patient according to my ability and judgment and never do no harm to anyone. So he set the first two principles. Do the best for the patient, do good for the patient, and do no harm. That was the very first two principles came from Hippocratic Oath. Then in 19th century, we came up with the concept patient is the center of care. And that was everything should be done focused to give a benefit for the patient. Then in 1980s came the most common or the most popular medical bioethics and the 4 principles set by bishops and James Childress. First, respect for autonomy. Second, beneficence, it means do good for the patient. Non-malfeasance, it means do no harm, and justice. That was the first 4 principles, and actually still standing till now. Then, an American group from psychologists, they said, added to it or changed it, and that was in early 2002, and they said they are not 4 principles, they are 5 principles, and they called it A, B, C, D, E, beneficence or non-beneficence, do good and do no harm. They did it as one principle. Fidelity and responsibility, integrity, justice, respect of the people's right and dignity. So that is it. Then another group in 2014 and European groups came with what they call it 7 principles: non-malfeasance, beneficence, also do no harm, do good for the patient, health maximization, so do the maximum efficiency that you do is, is real effective and professional, and respect autonomy, justice, and proportional. Then there is even one colleague from United States. He came with another principle, but didn't stand alone. This is only one principle: patients first. But this is actually the implementation, and this is also comes again to the old method: patient is the center of care. It's not the principle of it. Then we came with Mark Bernstein to this what we call it value-based medicine, which is actually patient is in the center of care. And in order to give the best care for the patient, you have to have knowledge. And this comes to evidence-based medicine. You have to have skills. You have to continue learning, and you have to apply the best technology. And all of this has to be done and help you in a frame of building a strategy and vision and do the best for the patient. And all has to be in a rigid frame of medical ethics and the values for the patient and for the community and for the doctors themselves. So definition of values-based medicine, which was introduced in 2014, value-based medicine is the concept to ensure that the principle of medical ethics is strictly implemented and observe it in every step of patient management. Values-based medicine is integration of patient preference into clinical practice. Value-based medicine is merged in order to stress that the medical practice is based on values as well as on evidences. And that is what is written about it. We have actually in values-based medicine, we have 6 different principles. Autonomy as shared with everyone, and nobody can debate about it, and that's important, autonomy, and beneficence, do best for the patient, non-beneficence, do no harm, justice, dignity, and honesty. Welcome. So if we go through them quickly, autonomy, the patient has the right to refuse or choose treatment. And this depending on the patient culture and social and family ties, and also age. That is what about dealing with the children, neonates, or an older patient, or senile, and psychiatric patient, and facing this, patient panic, cannot make decision. So there are many factors. So it is not a straightforward issue. So this is also comes in it what we call it patient, physician, patient, family, really complex relationship. It is not a simple relationship because it is a relationship between the patient and doctor, which should be straight. In many cases and in many conditions, it's not really straight. Families are between the patient and the physician, either directly or indirectly. In children, it is clear. You cannot actually go to the pediatric patient without going through the family. So patient has rights. He has the right to fair and good treatment and follow up. He has a right to be partner in making decision and the right to refuse treatment. He has a right to consent for every step of the treatment. He has a right to confidentiality, privacy, and dignity. He has a right for education, to learn about his disease, outcome, and long-term outcome. He has a right to complain, again, if he sees there's anything not done right and probably with him. But that's not all. Doctors, we have also rights. But we have duties and tasks. Our main duty to respect the patient right, to be honest to him, to admit if there is any mistake, to do the best for the patient, and to be available for discussion and to stay current, to train residents and do research and work in a team. Second point is do good for the patient, is act on or do whatever you do, but for the best interest of the patient. So that is which comes as a second, and this is one of the most important obligations. Non-malfeasance, first you do no harm, which goes back to Hippocrates, and actually needs from the philosophical point of view and the ethical, what is harm? Is surgery harm? Is it expected or not expected complication? Harm. Is it the clinical worsening or deterioration after treatment? It's harm. Is it the error or the mistake? Is it the negligence? Is it the violation of the patient right? So actually harm can be described in many different ways. But in order to really implement what is doing no harm, we have to come to a very clear definition. What do we mean by harm? And in this case, for example, if I'm doing my first operation and applying new technology and things goes wrong, who is responsible? This is not only a technical problem, but it is an ethical problem. So in fact, doing no harm and do good for the patient, the oldest two principles of ethics, which all principles of ethics, all over the history included. So, and make it very simple, do no harm, one ought not to inflict any harm on the patient. So you should not have no intention at any way to inflict any harm of the patient, or by either neglect something could harm the patient or use something maybe you are not sure about could harm the patient. For instance, do good for the patient, To prevent harm is good for the patient. To remove harm is good for the patient. And to promote good and cure patient is good for the patient. So this is mostly two principles. There are different perspectives. And of course, in these 2 points, there's a lot of philosophy. We can actually talk hours about really the relationship between non-malfeasance and beneficence. Maybe we can talk about it in another talk. Then come to the fourth one, which is really important, justice. What does mean justice in medicine? And medical ethics and human rights. Actually, the first in the United Nations human rights, the first item is that the patient has right to food, water, housing, and access to medical facilities. So the right to be treated is one of the fundamental human rights. But healthcare is expensive and just conflicts and dilemma. Well, social, health, economy, cost, availability in every place, and the waiting list. And how can we treat the patient equally? Do we treat the patient as what they need to be treated or as they deserve? Extra service, rich people, any other things. Okay. So for example, to make the things, if we are talking about ethics and medicine as a global issue, this is just a demonstrating case. There is 3 children, almost the same age, all of them, they have the same disease, hydrocephalus. One treated properly in the right time with shunt, one treated delayed treated, but he's already managed, and one suffered and without proper treatment. So Aristotle said, we are required to treat similar cases alike. This is one of the bases of justice in medicine. But do we do that? And if we would like to do that, how to do that? So that is what is justice. We are not talking about equality, but we're talking about equity. So if we look for equity in medicine, to provide the minimum, that is we can, most of the people, they can enjoy the good health, because actual equality, it will be impossible. So, of course, money playing a very important role in it. Then I will go to one of the very important, which I personally consider is the core of medical ethics, dignity. Patient dignity is the central to ethical medical practice. You have to preserve the patient dignity by all means. That is the basic human right. That is the patient right. This is the meaning. Without preserving the dignity, don't talk about ethics. Don't talk about proper medical care. So last thing which we added, actually, it was also added honesty. Honesty, that is, the doctors and the medical staff, they have to be very honest with the patient. If there is a mistake, they have to be admit without just make it clear and explain what's happened. They shouldn't hide anything about the patient, even the bad outcome or complication. And we have to learn the skills of how to deliver bad news. So this is honesty is very important ethical principle. That's why we added as the 6th principle for values-based medicine. Then, if we look for these 6 principles, can we see there is a conflict superficially? Maybe you can say there is a conflict, but how to be avoided? So, for example, autonomy and beneficence between the patient right and do good for the patient. I want to do the best for the patient. But what's happened if the patient refuses surgery? And I think surgery is the best thing for the patient. How can you convince him? Or how can he use it? This is also respecting patient wish. It is an ethical issue. But you have to respect it. After really, you give him all the information in his own language, in his simple language, tells the way he will understand. In the situation when he has a peace in mind and ready to understand and absorb that he has a serious disease, for example, and need to be treated. You just don't need to throw all the bad news in front of him in one go and say that he refused surgery. Also, the conflict, superficial conflict about beneficence and non-beneficence. As trial, a new concept, trial surgery, trial invention, all this comes in that area. Then, of course, justice and do good for the patient. In cases of an availability of expensive treatment, equipment, what you do. For example, patient needs small AVM and you suspect that the gamma knife would be helpful for this patient. There is no available gamma knife in your place. So this is, for example, that is one of the things which you should consider for making a decision. Here will come again, is there is a conflict between evidence-based medicine and values-based medicine? We think no. Evidence-based medicine is one of the important signs and achievement in modern medicine. There are ethical issues related to evidence-based medicine. As we said, how evidence is an evidence. This is something very important to see. Not, you have to see how the evidence is considered evidence. Most of the studies are coming from randomized studies, but how large is the data collected? And there are actually inherited problems of the large data and inherited problems of randomized study. So actually, it's important to really recognize the ethics of collecting an evidence and the evidence to make that evidence is an evidence. So actually, when we go to evidence-based medicine and values-based medicine, if we compare these two figures, we find in evidence-based medicine, they are talking about, there are three main elements about research-based evidence, or clinical accumulated experience, and then patient values and the preference. And this is patient values and the preference takes you directly cross board to values-based medicine. And when you look for values-based medicine, you found their knowledge, evidence-based medicine. So actually they tie together. They are complementing to each other. They are the same thing, doing the best in the end. Patient is the center of care. Either I apply, get the evidence to treat the patient in order to provide the best care, or to apply the values and the medicine, values-based medicine, to ensure that it's this care which is going to be implemented, this care which is going to be offered for the patient is acceptable and it is the best for the patient. So actually they are complementing and integrating together. So, and that is actually when we wrote about it, and that was our conclusion. So I just at the end come to illustrative cases to break, to highlight all about what we said. This, for example, patient with severe head trauma, marked shifting of the midline, and then the issue, and he came to that hospital, his glaucoma scores 3, pupil dilated, but still sluggish reaction. And the family pushed to try to do everything possible to treat the patient. Patient was over 40 years old. That is, they did decompressive craniotomy, and the patient remained, as expected, more than 2 years in vegetative stage. He survived. Okay. Who should make the right decision for doing the decompressive craniotomy? Is the neurosurgeon, or the neurosurgeon with the family, or social service can be involved in it? But I think that it's a neurosurgeon has to tell the family the truth and the expected outcome, but don't say that this is definite outcome, because some actually patients they improve and some patients they die. So that is, you say this is the expected outcome, and it goes like that. And once they reach the decision together, you come with the decision. Another case about this, This is also one of my patients. He's 63-year-old patient admitted to the hospital. He was always healthy, never been admitted in a hospital before. He has a severe dorsal pain. We did for him an MRI. He had multiple metastatic tumor. We offered him surgery. He refused surgery. So actually his son was a doctor. So the problem is how to deal with him. Shall we just say that the patient refused the surgery and discharge him? Or you have to second way, that's because you think that is really doing surgery will prevent the patient from going, still he is able to walk at that stage. That is to prevent him from being definitely paraplegic and lose the sphincter control. So this is what is, we need a second sitting with the patient. We can consult him, asking him for his privacy. Would you like to get some of your family, your son, your wife, your brother, anyone would like to sit with us? And of course, that's what's happened. He wanted his son to be there. And then we discuss and make it very clear and make it simple in his own language and in his way, and let him at the end. And don't ask for answer at the same minute. Let him stay 1 day or 2 days thinking about it. If he wants to get second opinion, give him a medical report and ask him, go for a second opinion. And you are still in the hospital and your bed is booked for you. Go for second or third opinion and then come. By this way, that is, he will trust you more and will come to the decision. So in case 3, about this is a problem. This is also 46-year-old gentleman was operated for L4-5 microdiscectomy, 18 months prior to his visit. Post-operative, he was fine for 1 year and then started to have back pain. And he asked a second opinion and he was told he had failed back surgery syndrome. Actually, this is true. That is, a patient didn't wanted to get a paper, a report in his mother language to explain what is failed back surgery syndrome. So the translation, very simple way, that is, your back surgery was failed. Do you think anybody likes to know that his previous surgery is a failure surgery? It's a failed? This is non-ethical terminology. And this is, I don't know why this terminology came to the medical field. Why we don't have failed heart surgery syndrome? Why we don't have failed renal surgery syndrome or failed hepatic surgery syndrome? Why it is failed back surgery syndrome? And when you go, it is actually introduced not by neurosurgeon. I am not going to do in this, but actually this terminology has a very bad psychological outcome on the patient. This is absolutely an ethical terminology, which should be deleted from our medical dictionary. This is, for example, this is the patient. He has a disc. As you see the post-operative view, the disc is completely removed. This is just post-operative adhesions, which is there, which cause. This can be called post-operative adhesion. As it was before, post-laminectomy syndrome rather than its microdiscectomy. But failed back surgery syndrome, I am absolutely against this terminology, and I think it is an unethical term which should not be used at all. Then, last case, what I'm coming to, which is also critical, this is also one of my patients. 4-year-old child had been complaining of headache and right side and weakness and in the right side and the multiple cranial nerve palsy. MRI showed brainstem tumor and it was actually cavernous angioma. We offered the child the surgery. He was 4-year-old. And of course, we told the patient about the risk of surgery. It is a brainstem surgery and so. And the father, of course, he has all the right. He asked several questions, which many of us, the neurosurgeon, was us, we don't like to hear, but we should hear. How many operations like this did you operate, doctors? Do you know any other place which can operate this patient better than you do? Do you have all the facilities needed for such surgery, or there's other place may have better facilities. Patient, father and parents, they have absolutely right to ask this question. And your duty to answer this question clearly. And when you are honest in answering the question, and this comes to honesty, it's a principle of values, ethical principle of value-based medicine. When you answer honestly, the patient will respect you, as is the father, and accepted that we operate the patient, and we operated him, and the patient has improved after that a lot. So these are the cases. So if I can summarize, come to conclusion, ethics or medical ethics is a complex field. Over 1,000 years, humans have not yet developed ethical theory to satisfactorily handle all issues of healthcare. Medical ethics, although generally universal, are interpreted differently in different places. Values are also relative, so that values-based medicine is a subject to relativity of a religious belief, culture, milieu, politics, laws, geography, and others. There are clearly ethical relativism in that what is considered morally acceptable or desirable in one culture, country, religion may be ethical, unacceptable, or undesirable in another, and should be respected. These varieties should be respected very much. It doesn't matter which type of ethical theory principle could you use and teach, as long as a core and spirit of ethics is patient is the sole center of care. Whatever I do is for the patient. I train myself harder for the patient. I read more for the patient. I consult more people for the patient. I get more equipment and best facilities for the patient. That is the core of the ethical theories, regardless you call it bioethics, medical ethics, values-based medicine, 6 principle, 10 principle, 100 principle, 1 principle. The end patient is the center of care. There is great need to include values-based medicine and bioethics and the medical ethics in every medical and surgical and neurosurgical training program. It is the time that we have courses about medical ethics, and that is the people they realize. They do it. We do it every day. We do it with every single patient. We do it in every hour. We do it even in walking and chatting in the corridor about the patient confidentiality and many things. So we have to, what is the frame? What's the platform of this ethical practice, and how we can guard our practice to be within a solid or rigid frame of ethics. Bioethics should be part of the curriculum of all medical school as well. Thank you very much.
Yeah.
If any question, I'd be very happy to hear.
Thank you, Professor Ammar. Beautiful presentation of a topic we don't normally, hear about or lecture about, or so it's a great refreshment for us to have you speak to us in a nice way to explain a topic that we all must understand better in the management of the people we take care of. So really a beautiful presentation, Professor. I also want to welcome Natalia from Ukraine as one of our moderators. Natalia, it's good to have you with us.
Yes, hello everyone. Hello, Dr. Professor Salim Abdulrauf. Hello, Professor Ahmed Ammar. I am representing the organizing committee. I'm a neurologist and also assistant professor in Medical University in Kiev. So it's really a great pleasure to have you today with us. We are a bit sorry for the beginning of the lecture with this a bit misconceptions, but we are happy to have you with us. And I also would like to say a few words, because having such a person during this Congress, it's really a great pleasure, and not only a pleasure, it's an honor, because ethics, it is something what, like, we are doctors, we don't have to care only about the titles and the result of our work. We have to care about the mental impression we do on our patients. And if we are good in the ethics and all that stuff. So we have to care about every detail patient may need from us. And I read your like CV, Professor Ammar, and I'm really impressed because having such training in the Europe, in Japan, and also then did a lot of investigations, create 4 surgical instruments which are used until now and manufactured by many companies. It's really great. So, and also like I saw that you operated more than 6,000 patients. I'm sure you are able to talk about the ethics, because to take care about such many people, it's really like, it's really have something to deal with. So thank you for today's presentation. I saw only like the small half of it, but I will read your books. I already saw them, Ethics in Neurosurgery Practice. So I'm sure I'll read it, and I hope it will help me in my future practice as well. So thank you a lot.
Thank you.
Thank you very much. Thank you, Professor Salim. Thank you, Natalia. Thank you, everyone. I really enjoyed very much. That is, it's giving me such honor to be with you and your kind words. I know this is ethics, as we said, you know, before 2014, 6 years ago, was no single book in the libraries about neurosurgical ethics. Our book was the first. And since that, we started. Now, as I told you before, but I tell you, 5th book is coming within few months, number 5, also neurosurgical ethics. And now we have active format. You are all more than welcome to join us. If you have any questions anymore, I love very much to talk with any group, grand round, anywhere, because it's needed. We do it, but we don't know that we are doing it. We just have to talk about it.
Yeah, Professor.
Thank you very much.
Yeah, this is great. I want to ask you a question, Professor Ahmed. As I travel the world as a visiting professor and lecture many places, I am astounded by the fact in many countries there is healthcare for the citizens, but no healthcare for people, for workers who work from foreign countries in their nation, or other countries where there's healthcare in private where people can pay. The people who cannot pay, there is no healthcare. What is the obligation of societies that to provide healthcare to its people, given the 2 examples I just shared with you that exist in the world today? What is your view about that?
Well, that is, I tried to make it very simple in the literature. Access to health care, it is included in the first item of the United Nations Human Rights Declaration. So you cannot deny any patient, you know, an access to the health care, regardless he's from the same nation or no, he is criminal or no, he is poor or rich. You cannot do this. Patient has the right, human being has the right to be treated. Then came the question, healthcare service nowadays is very expensive. We cannot make it in some countries, especially low-income country or moderate-income country, cannot give the same highly equipped, as they give example, gamma knife to every patient. So we come here, the question of equity means that is, I will have not the same kind of service, but I should have other option which efficient enough. So for example, if I cannot have a gamma knife, I should train young neurosurgeon. They will never be like Professor Salim, so skillful, but at least they know how to deal with this, how to deal with AVM, how to remove acoustic, how to deal with this. If I don't have the money, I have hands, I have brains to train, to do this. So that is the thing is, but I will repeat it again. Every human being has the right to have an access to a proper treatment.
That's very nice, Professor Ahmed. That is a beautiful words to end this session with. We appreciate having you with us. and for your beautiful presentation. It is nice to see you after so many years. I wish you and your family and your colleagues the best. And we are honored to have you with us today.
Thank you very much, and looking forward to see you again.
Yes, sir. Thank you.
And please keep in touch.
Of course, we will.